Hello everyone, my name is Elizabeth Tully and I'll be the facilitator for today's webinar, Post-Abortion Family Planning, a glimpse of global evidence and its impact with country implementation. We're pleased to host this webinar on behalf of the IBP HIPS Task Team, FP 2020, and the PAC Connection. If you aren't familiar with the PAC Connection, it's the interagency working group open to USAID-funded projects and USAID missions currently implementing or interested in starting post-abortion care programs. We hold semi-annual meetings and provide periodic updates and newsletters through our mailing list. If you would like to become a member, please email the address shown on the slide. Next slide. I'd also like to alert you to the Post-Abortion Care Global Resource Package. This website serves as a repository of basic materials intended for policymakers and program planners for designing or revising a post-abortion care program. It also provides past newsletter issues and meeting minutes from the PAC Connection. Next slide. Turning our attention back to HIPS, today's event is the fourth in a series of High Impact Practices webinars highlighting service delivery practices. This webinar is focused on the high impact practice of post-abortion family planning. And what is this proven high impact practice? Providing family planning counseling and services at the same time and location where women receive services related to spontaneous or induced abortion. Next slide. Lastly, if your project is implementing this high impact practice or any other high impact practice, please add it to the HIP map at the website shown on the screen. Next slide. A few things to keep in mind before we get started. We will have our panelists share their insights and experiences implementing post-abortion family planning programs in diverse settings, highlighting both challenges and opportunities. After the panelists present, we will have questions from the audience. Please type your question in the question box of the control panel on the right side of your screen. I will direct the questions to a panelist. Please note that the presentations and the recording will be sent to all of you tomorrow. And there are several handouts in the handout section, also in the control panel, which include the HIP brief, a post-abortion family planning consensus statement endorsed by key donors and organizations, and a short form to fill out your post-abortion family planning program for the HIP map, just as an alternative to filling out the map form online. Today's panelists are Juliana Bantambaye, Carolyn Curtis, and Aaron Melke. We will hear from Carolyn and Aaron first to provide the global context before we move on to hear from Juliana to share with us key lessons at the country level. Please join me in welcoming our panelists today. Carolyn, please go ahead.
And exciting. Next slide, please. An overview of the presentation. Today what we'll do is to touch briefly on global initiatives related to family planning and maternal child health, look at how post-abortion care family planning can address these areas, look at the demographics of PAC clients, high impact interventions that we know of, and resources for post-abortion care programs. Next slide. On September 25th, 2015, 193 United Nations members adopted the new Sustainable Development Agenda, which contained 17 sustainable goals for development. Out of these goals, 2 of them really relate to maternal child health, newborn and child health, and also women's sexual and reproductive health. Those 2 SDGs are SDG 3, which has global targets for addressing maternal, newborn, and under 5 child mortality, such as reducing maternal mortality rates to less than 70 per 100,000 births by 2030, and preventable deaths of newborns and children under the age of 5 by reducing neonatal mortality to 12 per 1,000 live births, and under 5 mortality to 25 per 1,000 live births, and to basically ensure reproductive health and gender equality and sexual and reproductive health and rights, which is under SDG number 5. Next slide. In 2012, SP 2020 was initiated, which addressed the desired family planning requirements or advancements that would be done by 2020, which would include the increased use of family planning by 120 million women and girls, additional women and girls, prevention of unintended pregnancy to reduce child death, and the use of family planning to reduce maternal death. We know that if we were to scale up family planning, that we would be able to prevent unintended pregnancies in 74 countries. This would avert 78 million of the 147 million child deaths. It would also, in 1 year, prevent an estimated 272,000 maternal deaths. Next slide. So you might wonder, how does post-abortion family planning relate to any of these global initiatives? We know that for newborn deaths, 35% of newborn deaths are related to preterm birth. And while some of the risk factors are not all listed here on the slide, there are a few in which post-abortion family planning can have some impact, such as the risk of low and high maternal ages. We know that there are greater risks for preterm birth, interpregnancy intervals less than 6 months, maternal depletion, nutritional status, where because of closely spaced pregnancies, mothers have a poor nutritional status as they begin the pregnancy, and this impacts the outcome of the pregnancy, which can result into preterm birth. So post-abortion family planning is able to contribute and address these factors. Next slide. Many of us have seen this data related to maternal mortality. Basically, 1 in 4 women in the developing countries have an unmet need for family planning, meaning 220 million women with an unmet need. And we also know from Guttmacher that the unmet need for family planning is a major causative factor for incomplete abortion. Every year, there's 210 million pregnancies, of which 80 million of those are unintended pregnancies. Those unintended pregnancies, half of them will result in abortion, safe and unsafe, and also with miscarriage. We do know that complications related to unsafe abortion contribute to 9% of all pregnancy-related deaths. Every year, 67,000 women are dying from unsafe abortion. Next slide. And so, when we look at post-abortion family planning, that this is one intervention that can provide a response to a number of areas, such as SDG 3, SDG 5, and the Family Planning 2020 goals. Thank you. Next slide. When we look at the post-abortion care model, I will say not just the USAID model, but all models that you look at for post-abortion care have family planning as an integral part of the service delivery. Since 1994, post-abortion care programs have been occurring in over 50 countries globally. It is one of proven integrated service delivery models that include both maternal health and family planning interventions. It would be important to look at the family planning part as, go back please, as a curative item in this particular component of services, because what it's helping to do is to cure the unmet need for family planning. We know that the treatment part cures the complications related to incomplete abortion, such as hemorrhage and sepsis. Next slide. We have looked at research for post-abortion care for 20 years. In our first review, which was published in 2008, there were a number of publications, 24 studies from 14 countries, that helped us to begin to look at who is this post-abortion care client. And what we know is that 65% of these clients are married or cohabitating or living in union. They have either 3 or more, parity is 3 or more, meaning that they've had 3 pregnancies or more that's ended in delivery. 35% of these clients are repeat aborters. 50% of them are interested in using a contraceptive method. Unfortunately, only about a third of post-abortion care clients were using a contraceptive method at the time of pregnancy. Next slide.
So now I will talk about what works to address these needs and the evidence that we have to prove this practice as a high-impact practice. So as you heard, the practice is to provide family planning, counseling, and services at the same time and location where women receive services related to spontaneous or induced abortion. Next slide. The theory of change behind this practice starts with looking at the barriers. And these barriers to clients include organizational barriers within health facilities, negative or stigmatizing provider attitudes and social norms, women's limited understanding of their own return to fertility after abortion, and the cost to access services. So you've heard the practice. The changes that are required in service delivery settings start with providing family planning counseling and services regardless of the method of uterine evacuation. Also, raising providers' awareness and understanding of how they can protect women's dignity during care. Offering a wide range and continuous supply of contraceptives. And task sharing and promoting service provision by mid-level providers. So you don't have bottlenecks where only the highest level providers can offer this care. And addressing cultural and organizational barriers to family planning use. The benefits for clients are several. First, women come away with a better understanding of their own return to fertility following the abortion or miscarriage. Second, women understand better about healthy timing for any desired subsequent pregnancies. This goes back to what Carolyn mentioned, including about maternal nutrition. Also, women or young girls who receive PAC care, now with strengthened family planning, have improved access to contraceptive services. At the population level, the outcomes include increased contraceptive use, reduced unintended pregnancy, and reduced repeat abortion. Next slide. So here are some key messages to share with post-abortion care clients in voluntary counseling and services. First, fertility can return within 11 days after an abortion. Second, women who want a pregnancy should wait at least 6 months after an abortion or miscarriage to reduce maternal and newborn health risks. These risks, you've already heard the newborn ones, but for the mothers, this also includes maternal anemia, premature rupture of membranes, and for the baby, low birth weight and preterm delivery. Third, in the immediate post-abortion period, all family planning methods can be safely used, including emergency contraceptive pills and long-acting and permanent methods. And please note, for IUDs, these can be used immediately if there's no uterine infection present. Next slide, please. Here is a picture of the consensus statement that was endorsed by many organizations, and this statement reflects the importance of post-abortion family planning as a key component within post-abortion care. This statement is a great tool for advocacy and for giving more details about what should be included in that post-abortion family planning in service delivery settings. And this statement has been used by professional organizations and other associations and large groups to be able to strengthen advocacy and implementation of post-abortion family planning. Next slide, please. So what are some elements of successful post-abortion FP programs? We see champions who lead changes in services, facility staff are sensitized, services are reorganized, and even invite male partners, if the client consents, to be a part of the counseling and understanding the post-care follow-up at home. Job descriptions are modified. We mentioned task sharing, for example, to mid-level providers. Also, service delivery protocols are updated, and information systems are created or updated, including client registers. Here, we're showing you a summary of some of the data you'll find in Table 1 in the Post-Abortion FP HIP brief. And what you see, please look at the two different shades of bars. The light blue is pre-intervention, so before sites strengthen post-abortion family planning. The dark blue bar is the results from post-intervention assessment. You'll see in the pre-intervention numbers, just under 10,000 clients were served. In the post-intervention, we have data on many more clients. It's over 13,000. Part of what changed was an improvement in data collection. But these sites not only served more clients in the post-intervention period, but they made sure that more of those clients left the facility with a family planning method. Focus on the last two bars. This shows you the median scores across all sites. These come from 15 studies in 13 different countries. What you see is, on average, at the pre-intervention measurement, only 32% of PAC clients received a contraceptive before discharge. At post-intervention, nearly 70% of PAC clients received a contraceptive before discharge from post-abortion care. The leftmost set of bars shows you the lowest scores, both pre- and post-intervention. So the worst performing site had a rate of 1% of PAC clients receiving contraception. And even the worst performing site at post-intervention had at least 25% of clients receiving family planning. The highest scores show you the best possible results measured. And there, at pre-intervention, 65% of clients got family planning before discharge, and by the post-intervention, we saw nearly 100% of those PAC clients were receiving family planning. Next slide, please. Here are links to important sources of information. We just want to share them again. The first is the HIP brief. The second is a link to the advocacy statement. And the third is the post-abortion care website, with many tools and resources for programming. So now I'd like to turn it over to Juliana Bantambia, who will share with you results from Tanzania.
Hello, My name is Juliana Bantambia, working for Gender Health Tanzania as a program manager for reproductive health family planning with the PACA program in Tanzania. Next. I'm going to share our experience on how we reached more clients with the decentralized PACA service in Tanzania. Next. Tanzania, like other development countries, our maternal death is still high due to several factors. Complicated abortion being one of them. Incomplete abortion is among the top 10 admissions in our hospitals and many women seeking for emergency management. But also we are challenged with unsafe abortion. Tanzania, abortion is illegal, but unsafe abortion performed by unskilled staff is leading to 19% maternal death from our DHS of 2010, which is actually a problem in our country. Next. Ministry of Health of Tanzania recognized the problem and strategized on how to overcome this problem. They included the PACA service in the minimum essential package of services to be provided in primary health care facility level. So in 2005, the Ministry of Health of Tanzania, in collaboration with Gender Health Tanzania, agreed to pilot the PAC services in rural facilities, starting with 11 facilities. After 1 year of the implementation, final evaluation revealed that the pilot was very successful and they recommended it to scale up in other districts. So from mission funding in 2007 to 09, we are able to scale up in a total of 16 districts, in which we reached the 207 facilities of Mwanza and Shinyanga region. And then by 13-15, we were also able to scale up in more 32 facilities, making it 239 up to date. Next. Our interventions focused at 3 levels: at the district level, facility level, and the community level. At the district level, we managed to have this district health management team who are oriented on their approach to be supportive to what will be implemented at the rural facilities. This team were able to identify facilities and select service providers for training. They were trained on, they are skilled on follow-up and supervision for PACA services. Also, we worked with them to include the budget in their annual plans for PACA services, mainly for purchasing the MVA kits. At facility level, jointly we conducted the assessment to establish facility preparedness for the PACA services. In collaboration, we had minor innovations to address infrastructure gaps, which were identified during the assessment. We trained service providers and the trainers per districts. And of course, the whole team at each facility were oriented on the service for clear understanding and guiding the clients to the proper area of services. Next. At community level, we aimed at linking the community and the health facility staff. Next slide, please. At community level, we linked the staff. Sorry, backslide. At community level, we linked the community and the health facility staff for education on PACA causes and the reduction of stigma, and also for creating a demand creation for services. And this also to reduce the 3 delays for timely seeking of services, and of course timely referring from household to the facility, and the timely management at the facility. Next, please. What was our achievements? Our main achievements was policy change. Formerly, PACA services were provided by doctors based at regional and district hospitals. Now the task shifting from doctors to, of course, needed to have a policy change. And also the MVA kits, which are formerly not available in our supplies, it was included in the essential supplies for easy access to the districts. And also several documents were developed and some were updated through gender health facilitation. Next. Some of our achievements were to reduce the workload to our hospitals because more clients were saved at the rural facilities and the more PACA clients were cancelled and discharged with the family planning of their choice. Next. Next slide. This is just showing one of the clients was saved and she was discharged from family planning. Demographically, you can see that from accessing data from each site from 05 to 14, it shows that 80% of the clients were married or in union and 60% of them are above 25, also above 3, birthday 3 and higher, but also about 50% of clients of cases happening up to 12 weeks. Next. This is just relatively to the clients saved at the hospitals and some relatively to saved at the hospital to show the workload reduction at hospitals. Next. This is also showing the total clients saved, the total cancelled and saved, and I mean discharged on family planning. Almost more than 80% were discharged on family planning methods of their choice. Next. This showing the method mix which were, where the clients that are choosing, but mainly was a short-term compared to long-term and permanent method. Next. What we learned, our main lesson is that if full involvement and participation of the government in the program can easily be sustained. When we started the program, the Minister of Health at national level, the coordinator for PAC service was appointed, who was able to solicit funds from our trainings in our project area, also for equipments like MVA kits, and inclusion of PACA service data in the national data system and supervision checklists, which are used at the national level and district level. But also local data service providers, if well trained, there is a direct impact on family planning services uptake for PACA service in all areas and of course life saving. Among the challenges, sometimes we experience short stock-outs of contraceptives, but mainly it's because of poor forecasting and ordering of service staff. And also there was an inadequate integration of other reproductive services like HIV, AIDS, and STI. Also referrals from very far health facilities for complicated test hospitals is still a challenge, and another challenge is the slow process of scaling up to other new areas. Hence the Ministry of Health focused, strategized on scaling up this service to the whole country, but we are still in 2 regions. Next. Thank you very much. That's the end of my presentation.
Thank you, Juliana, Carolyn, and Aaron for your great presentations. We have a few questions from the audience. The first being directed to Carolyn. Does the uterine evacuation method impact the type of contraceptives that should be offered to a PAC client?
Is that for me?
For Carolyn.
Yes. Do you want me to respond now, or do you want to put forth a number of questions?
Oh, please, yeah, please respond. Thank you. Okay.
So when we look at the different uterine evacuation methods that are available, we've got misoprostol, DNC, which is not the preferred method at all, but MVA, electric vacuum. I think the choice of the contraceptive method for the woman may make some will need to be considered when one is looking at the evacuation methods. We know that IUD, in terms of our long-acting methods, even though it is something that is safe to insert immediately following uterine evacuation, when misoprostol is used, it would not be able to be used until the evacuation is completed. So I think as one works with the women, sits with them, and looks at their reproductive intentions, it would be to really work with her to see what her choices are about her reproductive health intentions, what her choice is in regard to the contraceptive method, her ability to return for family planning when the use of misoprostol. So those things can enter into the conversation for which method to use for uterine evacuation.
This is
Great,
Erin. Can I also chime in?
Yes.
So what we want everyone to know is that all family planning methods are options for women who have post-abortion care based on the women's intentions. It's more of a question of timing depending on the woman's choice. And so the situation with meso is that the guidance is that providers give the meso and then ask the woman to come back a week later for a follow-up visit. And the challenge is for those clients who are not able to return a week later, and that may put some limits on what methods would be most effective for them in terms of effective methods and efficient services, and reduce barriers for the client.
Great, thanks, Erin. We have a question for Juliana. How does Engender Health join forces with other NGOs working on the ground to scale up PAC services?
Okay. Gender Health, when we started this program, no any partner was implementing this program. But to date, we have some programs which are scaling up, which I mean implementing this program, but at a very low scale. And some NGOs are just training the same service providers in the same facilities we have to add more, I mean to strengthen services. But just a few who are implementing this program in your country so far, especially in our area.
Great, thanks, Juliana. We have another question, but please type your questions in now if you have more questions for Carolyn, Erin, or Juliana. This is a question for Erin or Carolyn to answer about the PAC connection being open to any organization with USAID funding for any purpose, or does the funding need to be in a particular pot?
The answer is no. It's mainly what we wanted to do was to really be able to engage our partners and our USAID missions. And so if you're just getting USAID funding and interested in the topic, you're welcome to participate. We also have, on occasion, those who are outside of USAID, but we really wanted, part of this was to really help our programs to be able to really implement what we know to be high-impact practices, to be able to share across our projects as well as our missions. And so the answer is you're welcome to participate.
Thanks, Carolyn.
And I'll just add, for USAID, we co-fund our post-abortion care programming with both maternal health and family planning funds.
Great. I believe this one's for Juliana. How do you explain the low uptake of long-acting and reversible contraceptives among PAC clients in your program?
Sorry?
How do you explain the low uptake of long-acting and reversible contraceptives among PAC clients in your program?
The low uptake of family planning and post-abortion care, as I said, it's above 85% of the PAC clients are discharged on family planning method of their choice. The only challenge is that the higher percentage of clients are discharged on short-term instead of long-term and permanent method. So we are trying to strategize through another program to see how we can make a model of making these PACA clients to be discharged on the long-term and permanent method, and this model to be scaled up in other countries as a success or best practice.
Thanks, Juliana. Another one coming to you. In Tanzania, as 60% of clients were in the age range of 25 to 49, it suggests that a considerable number of clients were young women below 25 years old. What are some lessons learned from this experience with regards to offering PAC-FP services to adolescents and young women?
Can I get you? Sorry.
Do you want me to repeat it?
Yes, please.
Oh, sure. The question is, the 60% of clients were 25 to 49, so that suggests that there was a considerable number of clients below 25 years old, and they're asking what are some lessons learned from your experience in regards to offering PAC-FP services to adolescents and young women,
Okay.
if any.
It's true that 60% it was above 25 to 49 age. And also, this is also parallel to the number of parity, which is 3 and above. In normal circumstances, you find that women, if they are married at a very, not a risk age of 18, it's likely, if they space well, to have 3 children within 25 years of age. But this also goes with the several activities which are going on in the community, plus several infections and other things. But within this period of age, it's likely some women compared to prime, to those who are having the first and second pregnancy, to have abortions, which I think this can be a contributor to the number of parties she have, and the way she goes on with the age, this can also contribute to that. The second part of the question, the other lessons learned, you said the other lesson learned on this young age, because the service we are providing is all women who are coming with post-abortion problems. We don't mind if she has done safe abortion somewhere or she did what, but whenever she comes in, she has to be safe. So some of the age mate might be one of those which are trying to be induced or to do what due to different circumstances. But whenever they come at a facility or a client, they have to be saved in the same way. So what I think is at least if we can have a coverage of these young people with family planning, which we have already, of course, in our routine services, because we are covering the whole country with family planning, including in our project of PACA services. We have family planning at all levels, through outreach, through facilities. So at least all cages are covered through family planning, in which case automatically we are covering unwanted pregnancy within that routine services.
Thanks, Juliana. We're getting a lot of questions for you, so bear with me. Do you have any challenges regarding the purchase of MVA from USAID funding, and if yes, how do you address it?
Yes, according to USAID financial policy, we cannot purchase MVA. That's why I said that through government involvement, the Ministry of Health, they recognized that, and from the beginning of the program, the Ministry of Health was responsible to make sure they are looking for donors who can donate MVA kits. Up to date, we cannot purchase them. We are getting through Ministry of Health system, but also through district facilitation. They are now available in our medical store department, and the districts are including their budgets in their annual plan. So whenever they have a problem of shortage or to replace the worn out, they have to purchase them from them with MSD for replacement.
Thank you. This is a question about cost, and if you can give a relative cost of providing PAC services via DNC, MVA, and MISO, including training and equipment and supplies. The relative costs of providing PACS services via DNC, MVA, and MISO Prostal, including training and equipment and all the supplies.
Okay, when we started piloting this program, the first year of study of piloting was to study about 3 things. One was to document about the feasibility of the services, acceptability, affordability, and cost effective, so that the Ministry of Health can be advised on how to budget for scaling up to other areas. So from the introduction of decentralization of services through MVA, it seems to be cost effective comparatively to other methods of family of post-abortion care. For the Mr. I cannot say much because this is not yet allowed to be used randomly in Tanzania. And for the DNC, of course, you know, it's costly in many ways. Because when you are trained on MVA, the nurse midwife can easily perform the procedure and save their life. But the DNC is just performed by a doctor. So when the doctor is not available in man, it means clients will lose her life. So I can say the MVA is still cheap in terms of service provision at any level, and the local can provide the cost will come to the training for 2 weeks for each service provider. The cost will come about the equipment. The cost will come in terms of who is making a follow-up and data collection. But when you come to the DNC, the first cost is to have those equipment in place and have who is going to provide the quality service at the time when the woman will come seeking for treatment.
This is Erin. Sorry to interrupt. We've got a fire drill, but we called in on our cell phone, so we're still on the line.
Okay, thank you, Erin. Of course. Juliana, do you have any?
Yes.
Ados, do you want to mute them for the moment?
Yes, Elisa.
Yeah, sorry. Juliana, do you have any couples counseling strategies in order to have more male involvement in the post-abortion family planning services?
Men and women?
Do you have any couples counseling strategies to have more male involvement in post-abortion care services?
Yeah, male involvement is still a challenge in our area, although we are doing the best to make sure at least women men are involved, but through community involvement, education, to create awareness on the importance of having this women being managed environment, through the importance of prevention, because they will be aware of the causes of pregnancies, through the education on how should these women be prevented with an unnecessary death management timely. That's what we need to involve with men. At this moment, I think the woman with having bleeding can easily be spotted by her husband after the recent or dispensed and even higher transport to make sure her wife is well managed at the street. But it's more community involvement, using different groups, using community champions, using community workers. That will be the way you can involve. I mean, we can make.
We're hosting a webinar right now.
I apologize. We've tried to mute Erin and Carolyn's line, but it doesn't seem to have dropped them from the line. So I apologize.
Let me try muting.
Okay. Apologies for that. Thank you, Juliana. And we have another question about the health service providers that provided the PAC services. Were they the same people who provided the family planning services? So did you have the same health providers doing the same services?
Yes, those who are trained on PACA services are the ones who are trained on family planning, because soon after service provision, when the client recovers, she has to be counseled and given service providers in the same room without being referred to other area. So in each ward where there is this, we say VA room, when the woman is admitted, she has to be evacuated in the same room. There is a special room. The same room should have all family planning commodities, should have everything for emergency, and soon before discharge, she have to get the service according to her choice.
Great.
So the service providers, they are trained on family planning.
Great. And we have a follow-up question about the long-acting and reversible contraceptives. What are the reasons that clients are not currently receiving more LARCs within Engender Health Tanzania programs? And are they doing anything to strengthen this particular component?
Yeah. In Tanzania, it's true, they are decided on family planning, but mainly most of them are just taking short term. But why short term? Most of the clients, it's because most of them are still in the reproductive age. So most of the pregnancies are regarded as precious. So they think after abortion they should conceive as soon as possible. That's why most of them they consider to have short term. But also those who are getting long term, you find them either having more than 3 or even 5 paras when she don't expect it to have. In Tanzania, we are still having a good number of pregnancies with children. So through that strategy, we have a PAC F2 program. Caroline knows that, which is going to take over in Tanzania. I've started since last year to make sure that we are strengthening these senior sample facilities to have studied and be well documented, and to make it a model which can be scaled up in other areas, and meaning that how can a PACA client have an access to multiple family planning commodities of their choice, but mainly long-term and permanent methods. So hopefully in the future, we are hoping to have a very, very big change in this number of family planning mix. Most clients, I know, most of them will be having the long-term, and those eligible for permanent method will have a change through this program we have now.
Great, thank you. It seems we have maybe one more question left at this point, and Juliana, you'll be up for answering it, as Erin and Carolyn have left the webinar. The practice in the field suggests that most incomplete abortions are induced, and have you noticed the same thing in your program?
Pardon? Can you repeat the question?
I can. The person says the practice in the field suggests that most incomplete abortions are induced abortions. Have you noticed the same thing in your program?
In the program, for a few cases, you can know that through the history taking. You can know that this is not a miscarriage, a normal miscarriage. Through history taking, through examination of the cervix, if there is any trauma or other things. But otherwise, when the client comes at the facility for services, she gets service according to the condition she comes at the facility. But what we know, of course, it's illegal, but people are practicing. But the way you can assert the client that you have induced the abortion or what, that's not can be done. But we know it's in practice by some of the girls, school girls, and the other people, and even through the DHS of 1020, 19% of maternal death was identified as contributed by unsafe abortion.
Thank you, Juliana. I think we don't have any more questions, so we'd like to thank the audience for participating and asking these insightful questions. Please join me in thanking the panelists today and the various IBP partners that made today's webinar possible. We will be sharing the recording of this webinar with everyone and also posting it on the HIPS website on the web address shown on the screen. If you have any questions, please contact Ados May at the IBP Secretariat. Thank you, everyone.
You are welcome.